I'm going to turn now to Marie-France, who's going to speak to us about the experience with IRC, where they've done a lot of evaluations in the health system.
My voice doesn't quite carry as much as Dr. Fox's does. So can everybody hear me? Mm-hmm. Great, thank you. So today I wanted to share our experience as IRC. IRC, just very quickly, I think that most of you are probably quite familiar with some of the work that IRC does. It's very much a sister organization to Save the Children. We support people whose lives have been shattered by conflict and disasters. We work in over 30 countries, and also in the US we support refugee resettlement. And we work across 5 outcomes, so health, education, economic well-being, safety, and power. And we also have 2 kind of cross-cutting outcomes around improving service delivery and also gender equality. So the work that I'll present today obviously cross-cuts health and empowerment, but also this service delivery piece as well. And as well, the IRC does have quite a strong research focus, so I will first present 5 of our lessons learned in terms of how does social accountability work for health systems when you're working in these fragile contexts, but also then 3 lessons learned from trying to evaluate and conduct research on social accountability research on health systems. So about 10 years ago, we became quite interested in social accountability. Health systems strengthening has always been a cornerstone of IRC's work, so even though we work in very, these complex countries with protracted conflict and cyclical conflict, I would say except for where we have acute crises, that approach of working on health systems in this kind of horizontal approach has been quite key. And I'm very lucky to have my colleague Lara Ho with me, who's she's the team lead for health research at IRC, and also does a lot of work on health system strengthening and health and governance. So if there are questions that I can't answer later, she can definitely answer those as well. And as we were thinking about how do we improve that, we wanted to use both the top-down approach and that bottom-up approach. We want to work with governments, ministries, but we also wanted to work with clients to make sure that their voices are heard. So not surprisingly, when you work with a conflict-pathetic setting, your ministries and your government may be weaker for various reasons. So then, what do you do then? What happens? An example of that is, for example, in the Congo, we tried for several years to, our donors were very interested in working at a national level to work on user fees. And we just couldn't get really traction on that. So basically the idea was to say, let's continue to work at that level. It was quite important to continue that work, but also to say, let's work at the local level and to see what problems could be solved locally. But also to start that interface, this is something that Jonathan mentioned, is that at the local level, service providers are also part of the state, so how can we, in an incremental way, start with that relationship at that level? And to go back to the Congo example, for example, we've seen success stories where locally, when service providers were sitting down with clients and clients were saying, the fees are just too high for us, then that conversation started, and then in some cases fees came down as service providers realized that if fees came down, actually revenues would go up because more people would actually use the services. So we actually had local successes where we didn't have successes at the national level. Oops, sorry. So just 5 lessons learned from our implementation in doing this in fragile and conflict-affected states. Sorry, folks. So here are some of the countries where we've done this work at the intersection of health systems and social accountability. So that includes Sierra Leone, Congo, Zimbabwe, Jordan, Iraq, Pakistan, Myanmar, and Thailand. We probably are missing some here. This is just what we could come up with with the presentation. First lesson is that, in these fragile places, collective action still happens. People do come together, and they do action change. So, for example, in a lot of clinics, the clients were saying nurses and doctors are just not showing up. So people will work together and come up with some solutions to incentivize the nurses and doctors to show up. But the challenge with that is that obviously you hit a ceiling very quickly, whereas if the doctors and nurses are saying we're not showing up because we're not getting paid, that solution needs to be actioned at the ministry level, so that there's a ceiling to that kind of local action. Second is capacity to respond remains important. So here, this is similar to the video that we just saw. This is a community scorecard exercise where people are noting down this is the priorities in terms of the changes that we want to see. And IRC, after experiences in doing this, decided to support in providing some amounts of money to support these. So for example, if people identified training or materials that we're needing, IRC would say, we'll give you at least some small amount of funding to get this started. So if you want to do advocacy activities, we're going to get you some resources to get this started. Without this, we really felt like without the resources to action these, or at least minimal levels so that people could get this started, then it was ended up being a bit of an empty exercise. But of course, the flip side to that is sustainability. So how do you ensure that resources keep on coming in, even though the INGOs are not always there to do that? So obviously participation has a cost. And I must admit that as I look at especially two projects that we had, one in the Congo and one in Somalia, and I look at our theory of change, we had this kind of normative sense that participation is inherently good. That people are just looking for spaces to participate. They participate, and then they get their voices heard, and then services improve that way. In two studies, two impact evaluations, we found kind of a strange pattern, and I don't mean to generalize this. This is just what we found in two places, but is that people would say there are more ways for us to participate, and that makes us happy. Users committees, or like health user committees, are taking our feedback into consideration. That makes us happy. Service provision quality has improved, and that makes us happy. But they're not participating more, they're actually participating less. And then when we would do qualitative work and speak to individuals, they would say, well, yeah, I have so many other things to do. So if I know that there will be antibiotics at the health center and I don't need to add that, I would rather be in my field, I would rather be at the market than participate. Or another example that we saw, for example, in the Congo, is that they would say, well, we would need to take 1 day a month to do some of the grass roofing. So now that we don't need to do that, actually that saves our time. We'd rather not have to do that if we can. And also, service providers are also community members. So that kind of duality or binary relationship that you can expect is much more complex, especially from my experience in these fragile states where things get very localized, where infrastructure may be very poor, people are very much in their own communities. And that has there's a flip side to this. So on the one side, as we did community scorecards, for example, and we asked community members, broken down by gender and by age, what they thought of health services, and then we asked service providers what they thought of health services. We actually expected that to be quite different, for basically nurses and doctors to say health services are actually quite good. That wasn't the case at all. They actually very much agreed on the fact that health services had a lot of challenges, and they very much agreed on exactly what the challenges are. So that meant that we did not have to create the same level of information. They had the same level of information. The issue wasn't that, it was that they couldn't action on some of these problems. The other side to that is that, ironically, then community members would say, okay, now that I understand that the nurses, the reason why there's no medication is because the health ministry is not giving them the medication, it's not really their fault, I'm not going to ask them to follow up on that. But that was kind of one step too far, actually, because while the nurses aren't responsible to get the medication, they're still responsible to advocate to make sure that it gets there. And then, well, that's cross-cutting across everything that I said as well. It's basically, if you want to get these higher up kind of public reforms, obviously that requires political will. And this is something that, especially in a fragile state, complex affected state, that's something that can be a really, quite a struggle. And we certainly try to work at the IRC from the local level and then at the district level and up to the province and nationally. But yeah, often you end up hitting a ceiling, especially as there's so many issues on the table. Then a couple of lessons on trying to evaluate our social accountability work. And what I'm going to say here, it's basically not my judgment of these methods across the board. It's just our experience of it, and maybe sometimes our misuse of those methods as well. So just to keep that in mind. So we certainly used qualitative methods, which told us a lot about what and how local changes happen. And in fact, a lot of what I just presented in terms of on the practice came much more from those kind of discussions, and we use things like most significant change and outcome mapping to really get that kind of like understanding of the power dynamics and how change happens. But the way that we used it didn't answer bigger lessons. So for example, people could tell us, yes, this worked, but we didn't know, but would have something else worked better, for example. We are also running a number of randomized control trials that really tell us big picture, does this work? In terms of, do we get the outcomes that we expect? And for any of you who've worked on these types of impact evaluations, they take years to implement. We're currently working on one that is looking, again, it's in the Congo, and it's looking at bottom-up versus top-down, and the combination of both, and trying to see where we get most outcome, but it will be, I think, 4 years by the time that we get the actual results. And we work in these very rapidly changing settings. So we are very committed to that, but at the same time, it leads us to a challenge when the context is constantly changing, and also, again, can be very specific in these countries where you might have a region that's very conflict affected, some others are not, some of them tend to be very localized, some are not. We also tried other impact evaluation options. We tried, for example, interrupted time series analysis, or to use the data that's already existing and try to map it that way instead, so it's a much quicker turnaround. This is from a health clinic in the Congo. This is just like a pile of data. But that planning ahead is really key. So especially in the fragile context, that expectation that health clinics will have utilization rates for every month, or that type of information was in retrospect, I think, not something that we could expect. It was really uneven, and we had a really hard time collecting it afterwards. So just a few kind of final thoughts in terms of our experience in social accountability for health system strengthening. So certainly we do feel that it is quite promising in terms of supporting local level problems. Activating that with the upper level has been much harder. And we as an organization, something that we do want to learn more about is what works, not just whether it works, but what works where and under what circumstances, especially because these contexts are very contextually specific, and that we do as practitioners need much more of that kind of practical framework. And in terms of evaluation approaches, we are moving much more into mixed methods. So for example, right now, some of the big evaluations that we're doing combined randomized controlled trials with qualitative methods and with ethnographic studies. We'd like to explore positive device case studies as well to really get into kind of the details at the local level of success stories. And as well, we'd like to do more of the quasi experimental methods. So for example, using the data that's already at health systems and to try to do things like regression, discontinuity, and these types of methods, but we know that we need to plan them really well because we can't expect the data to exist at the local level if we don't plan it from the start. So I'll leave it at that.